spongiottic dermatitis. So in low power, we can see some area really had spongiotic changes, like this area kind of pale because there are more fluid between the keratinocytes. So we can see the cell have more space here. Then other than this, I mean, in examination, it's really difficult to test you for the spongiotic dermatitis because you will have tons of final diagnosis for this pattern. So everything from the dermatitis chapter are not specific. You have to have clinical picture or maybe other scenario for you to make the diagnosis. So let's zoom in a little bit. Yes, so you can see a lot of fluid space between each of the keratinocytes. So that's the reason we call this spinous layer. So this desmosome just like spider leg hook with each other, and then this desmosome also really important when you try to differentiate whether it is keratinocytes or melanocytes. Here, I don't know whether the resolution is good or not. Usually, if you have really high resolution, you could not see if this is melanocytes, you could not see this desmosome between the melanocytes and the keratinocytes. So let's talk more about this lesion. So spongiotic changes in the epidermis. We can see extravasated lymphocytes, some black dots around this slide. Then in the dermis, we usually will see eosinophil, lots of eosinophil. And then all the perivascular lymphocytic infiltration, non-specific at all, so you can ignore it because every dermatitis, you will see certain amount of perivascular lymphocytic infiltration. So we can see a lot of like lymphocytes in the epidermis and eosinophil. So this is spongiotic dermatitis. And then the differential is really broad. Usually we will write long, if we do not have clinical photo or any history, we will write down a long list of differential diagnosis. I think I already share a Word file. We have a happy differential. So all of the disease mentioned in that mnemonic, it can fit into the picture of spongiotic dermatitis. And then I want to show you some more, maybe more specific one. Okay, kind of slow. So this is a Kindle picture for, I think, this allergic contact dermatitis. Just like maybe this patient wear this watch, so and then allergic to some metal or any other stuff. You can see this vesicle in this wrist area, or maybe poison ivy, you just could not tell. But for this clinical picture, it's certainly really highly suspicious for allergic contact dermatitis. And then here is the histology finding. Even in low power, you can see kind of different with the spongiotic dermatitis. But this is kind of a, for the first slide, that is the really subtle changes of spongiotic dermatitis. But this one, you can also think about spongiotic dermatitis because you can see if the fluid just aggregates beside the keratinocyte, they have lots of fluid. So you can have this vesicle. And then let's zoom in what's inside this vesicle. Usually we will see eosinophil. You can see eosinophil inside this vesicle. And then we can see really dramatic spongiotic dermatitis. And then we can also see this waste basket stratum corneum. That means this whole process happened really fast. So the basal cell layer cell do not have enough time. They do not proliferate too fast and then maintain their nucleus in the stratum corneum here. And then in the epidermis, you can also see some eosinophil, perivascular lymphocytic infiltrate. So if you see this picture and then see the first clinical picture, you can make the diagnosis of allergic contact dermatitis. But also you just could not rule out like irritated contact dermatitis at the time of the spongiotic dermatitis. You just favor this one. Then this one, I moved one case here because I think they still fall into the same category. This is this is a tick bite, also called an arthropod bite reaction. So here we can see tons of perivascular lymphocytic infiltration. And then when we zoom in, we should see some spongiotic dermatitis here. Spongiotic dermatitis, and then tons of eosinophil. So this is but when you compare to the previous two slides, you can appreciate that a lot of lymphocytes in the epidermic perivascular, tons of lymphocytes. So this is another reaction. If this spongiosis is not really dramatic, or the changes just in the dermis, we will also say this term like DHR, dermal hypersensitivity reaction. So if you see these tons of reaction, you will highly suspicious whether this is something like tick bites, arthropod bites, even scaby. We have scaby in some slide in today's review. So, but some people are also thinking about, could it be any lymphoma? Yes, why not? Because this reaction is so dramatic. Somewhat like some people will like pseudo lymphoma, something like this, to describe this description. But usually, patient will have a history, something bite, or in the clinical photo, you will hear something like a nodule, and then the patient tell you really itching. So you will be highly suspicious, just something bites there and then cause this dramatic hypersensitivity reaction. And then usually in lymphoma, you won't see these tons of eosinophils. Then we have another one. This is a tick bite, also fall into the same category. But the reason I choose this one because you can see a tick mouth here. So I think if in text you can see a tick mouth, you just choose tick bite, whatever reaction you have. So you can see this something clearly not from human being. This is a tick mouth. So the tick bites our skin, and then they live. Maybe people take it out, and then you can see this tick bite here. So, and then you can see the reaction. We can see hemorrhagic here. And then, let's see here. If you do not see this tick mouth and then see this reaction, also spongiotic dermatitis, here is not really dramatic. But you can see clear hemorrhagic and some eosinophil, and then perivascular, lymphocytic, and eosinophil infiltration. But I think in the text, they should give you a tick mouth. They could not just give you this reaction to let you choose, because not really fair. So just remember, when you see this, just choose a tick bite. Okay, let's move to. Okay, this one, I think this one is the first case. Okay, I think this is the second case. This one is stasis dermatitis. Usually happen in the lower leg, especially in the anterior area. What we can see in the slide, usually because this stasis changes due to hypoxia. So that means the skin of the lower leg, they do not have enough oxygen. So the pathology changes will cause reactive vapsal hyperplasia. And then usually people will feel kind of itching in the lower leg. So you can see kind of a little bit a acanthosis here. That means the epidermis kind of thicker. Then let's zoom in a little bit. We can see turn of vessel proliferation here, but this is just secondary changes. That means this is hypoxic changes. So the skin want more oxygen or want more blood. So and then they just proliferate of this vessel here. We can also see some thrombi here, this pink material. And then usually if it starts really quick, we may see some extravasated red blood cell because I think when the patient just feel itching or any uncomfortable, they will scratch their skin, and then some vessel maybe just break, and then the red blood cell just go out, so we can see some red blood cell extravasation. But in a chronic lesion, I think just like this, we can see tons of this hemosiderin deposition here. So there's all of this not melanin. This is hemosiderin from the red blood cell deposition here. So I think that's it for this one. So you're just thinking this is not any tumor changes. This is just reactive. And then don't even think of this as maybe squamous cell carcinoma, something like this, when you see a lot of reactive changes here. So of course, this kind of hyperplasia and acanthosis of epidermis just due to kind of chronic scratch, something like that. And then I put another differential here. This one is called lipodermatosclerosis. The reason why I put this one, this lesion actually fall into the pandiculitis chapter. The reason I put this because for this lesion, we usually see stasis dermatitis changes in the superficial dermis, papillary dermis for this one. But when you see this big punch and then deep into the subcutes, usually you won't think about stasis dermatitis. You should think of why maybe the family doc, why the dermatology, they do this deep punch and then include the subcutaneous fat. But when you see the epidermis, if just show you this picture, kind of really similar to the stasis dermatitis. We have this small vessel proliferation here. Sometimes we may also see hemosiderin. So for this lipodermatosclerosis, if you want to make the diagnosis first, you need to see some stasis changes in the epidermis. And then in the subcutaneous fat, we want to see one pathognomonic changes. When you see this with the stasis changes, I think you can make diagnosis of lipodermatosclerosis. We call this lipomembrane changes. See this, it should be a adipocyte, but adipocyte, you can see this is necrosis of the fat. When the septate of the fat, I think the membrane, they just break apart, they will leave like this, like membranous changes. We call this lipomembranous changes. So these changes with the stasis dermatitis changes is highly suspicious for this lipodermatosclerosis. But I think for the broad, I don't think they will give you this line kind of too much. And then another changes, you can see this dermis. Usually in the dermis, we should see some fibroblasts. That means this pink material, we need to have more this nucleus stay inside. But you can see some of these collagen, they just lose this nucleus. That is one of the changes we call the sclerotic changes. So this is not just fibroblast proliferation because they lose their nucleus, just this thickened collagen without nucleus. And then this is another differential diagnosis. That is the capillary hemangioma. For me, I don't think this is really a mimicker or make you confused about the stasis changes. But it seems in the book they put that there, so I just still put here. We all know this is a dome shape, maybe a nodule, because if the epidermis, I mean the skin just something like this, something just punch out like a nodule. I don't think the stasis dermatitis you will see any punch out nodule, something like this. And then even in this low power, we can see tons of vessel proliferation, but they kind of forming some kind of structure, like they have a nodule or maybe lobulated structure, something like this. So this is a hemangioma, not stasis changes. So I think this one is not really difficult to differentiate with the stasis changes. So far for these stasis changes, any other question? Or I can move on.